Dear viewer, in this video we present a brief introduction to the new ICPC-3. My name is Kees van Boven and together with Huip de Napel we are project leaders of the ICPC-3 consortium. The consortium hosted by the Radboud University Nijmegen, the Netherlands, at the Department of Primary and Community Care consists of several representatives from international bodies and scientific associations. On behalf of the colleges, the representatives take part in the development of the new classification. The ICPC is the most widely used international classification for the systematic recording and organizing of clinical information in primary care. How did we make the choices of the classes? The choice of classes, also called rubrics or categories, is based on the classes in the previous version of the ICPC, enriched by proposals from the Wonka Classification Committee and from the consortium members themselves. As it has always been, that choice of classes is based on frequency of occurrence and use in primary care. Classes with symptoms, complaints, illnesses, problems, examinations, policy and information about functioning aspects that are frequently discussed in daily practice all have their own code. Less frequent morbidity items are captured as inclusions within the categories. The organization of the complaints, functioning and the action or intervention of the provider is at the episode of care level. In a separate video we present the application of ICPC coding in primary care. Now, how is the classification composed? The ICPC-3 is divided into chapters and subdivided in components and the components in the classes. The classes have a code that consists of 4 digits. So, as an example, the chapter R. By clicking on the triangle in the front of the folder opens and you see the components RS and RD. The S stands for symptom complaints and the D for diagnosis and problems. Then click on RD or RS triangle again and the coded classes will appear. So I will click on it. For example, RDO1, pertussis, whooping cough is the first one. In the right-hand window, you can view more. You can view more information about the content of this class, such as a description of the disease, the inclusions, sometimes the exclusions, and links to the previous versions of the ICPC, ICPC 1 and 2, but also to other classifications like the ICD-10 or 11, or to a clinical terminology SNOMED CT. We will explain the linkages to other classifications in SNOMED CT in a separate video. We will now close the chapter R again by clicking on the triangle. We will now continue by looking at chapters that stand out from the more traditional chapters. The traditional chapters are the chapters that are organized and named according localization or body system with the 2 components, as you just saw, complaints, symptoms and the diagnosis. But first to the 4 different chapters. The classes in these 4 chapters make it possible to identify family planning and prevention, social problems, examinations and policies, and possible problems with activities and participation. This kind of information is key in order to be able to understand what's happening in primary care from a patient's point of view. First, the chapter A1. In this new chapter, we distinguish classes where there is obvious no health problem. The components in this chapter, indicated by 2 digits, are family planning, general and routine examination, introduction and patient treatment preferences, prevention and case finding, public health promotion, and the last one, the residual component group. The components are populated by classes with a 4-digit code. In family planning, for example, are the different types of contraception. Also here, the code of the class consists of 4 digits. Again, when clicking on the code, you can see on the right hand side of the screen more information about the selected class. We'll now close this chapter again. In chapter Z, the social problems affecting health are classified under the component ZC, social problems influencing health status. We open this chapter again and you can see more than 40, more or less, 40 different classes. I will close this chapter again. In the chapter with the Roman 1, the interventions and the processor are the classes that describe the actions of the provider. By clicking there on the triangle again, this chapter opens with a different component. Both the diagnostic actions or interventions, such as doing a physical examination, request for a blood test, etc., as well as the therapeutic actions, prescribing, vaccination, giving advice, can be coded. And in addition, it's now possible to record also programmatic care, such as cardiovascular risk management, and also we have a program for frailty elderly. I will close this chapter again. The fourth and completely new in the ICPC is the chapter Functioning in Relation to Health, Chapter 2. This chapter provides a specific selection from primary care. For instance, here clicking on, you see the functioning. In the functioning we have 2 different groups, 2 different categories. So the activities and the participation and the functioning. We think that capturing this kind of information is very important to the patients. It's also important to get an impression about the outcomes of our actions. In a separate video, we explain more about this chapter. In the 14th chapter, B to W, the complaints and the diagnosis are organized according to the body system. This has been done in a uniform way, which makes it easy to find the right class. So the chapters contain 2 components each. Let's go to the I. Component S for the symptoms and component D for the diagnosis. The classes, they show a color, and the color attributes in the disease component indicate the etiology, such as the infections, neoplasm, the traumata, the congenital, and the other. Chapter A is organized, the general chapter, in the same way as the chapters B to W. However, Chapter A contains symptom and diagnosis that cannot be linked to one system or can be linked to more than 2 body systems. For example, I will open the symptom part. Fatigue and fever are symptoms that can be linked to diseases from almost all body systems. And if we go to the disease part, And then we go to tuberculosis. It's also in chapter A because it's a disease that can manifest itself not only in the lungs, but also in many other organ and body systems. So I close this chapter. So in addition to those 19 chapters from A1 to Roman 2, there are 3 additional chapters. There are the chapter with the regional extensions. That means that these are classes. They have been assigned a 6-digit code based on frequency in national and regional primary care registrations. So these regional codes are included within the 4-digit code. For example, if we open the African extension, we see Lassa fever, AD 14.05. So it's also visible in the inclusions of the core. So in AD 14, and there you see the Lassa fever with its own code, with the regional code, is also visible in the core part. At this moment, we have subsets for Africa, Europe, and South America. Chapter 4, Roman 4, the emergency codes. They contain classes with code for new diseases that can be used in emergency situations of epidemiological importance, given the risk of spread of infections. And these codes are aligned with the ICD codes. And final, we have the chapter 5, the extension codes. These codes can be used as additional codes or as additional position to give more details or meaning to the original code, if desired. The extension code should not be used without an initial code. For example, the classification of severity of COPD and heart failure can be found here. So if you go to the scale value, there you see the scales for Gold 1 to Gold 5 and the New York Heart Association classification for heart failure. In the next video, we will focus more on the chapters A1, prevention and functioning, and the field testing. Thank you for watching this video.